Progressing through our organ systems, we're now going to discuss ear, nose, and throat. Some of the things we've already mentioned for the ear, such as the ear malformations at birth. So now we're going to go into some different subjects that have to do with the ears. Otitis externa, and we'll discuss otitis media after that. Otitis externa is also known as swimmer's ear. And the reason it's called that is because it's usually due to a repetitive wetting of the ear canal, also secondary to repetitive trauma to the ear canal. That is why we don't like to put things in the ear canal. We try not to put swabs and Q-tips and things like that in the ear canal because it can cause repetitive trauma. It can also pack in the earwax. Symptoms of otitis externa are going to be ear pain, especially on manipulation of the external ear. That's what you have to look for when you're reading the test question. Look for a history of repeated trauma or a history of swimming, being underwater a lot, and then look for a physical exam finding of ear pain on manipulation of the ear. Otitis media can cause ear pain, but it's not going to be exacerbated by moving the ear, the external ear. What you're doing with otitis externa is that whole area of the outer ear and the ear canal is all skin, and so when you move it, it's going to be inflamed and it will be irritated and it'll really hurt. There is no best test except for looking in the ear, and you see a very swollen, macerated, angry, red-looking ear canal. If you can get a look at the ear drum itself, it will be normal. Treatment of otitis externa or swimmer's ear is basically done with topical antibiotic drops, and you can prevent it by wearing earplugs or trying to keep the ears dry. Sometimes if you're underwater for a lot, if you come out, a couple of drops of rubbing alcohol in the ear canal flushes out the water, and then the alcohol will evaporate. Here you have a picture of a very angry, very red ear canal. It's also going to be swollen, and you sometimes get this kind of cheesy looking stuff in the ear canal itself. And these guys are having a good old time at the beach or at the pool, but they need to keep their ears dry because that can lead to otitis externa. Otitis media is now basically the middle ear, and it's going to be an infection there. It's almost like a little mini abscess there. Risk factors for otitis media include your age. Younger children and infants are at higher risk. One of the reasons is because of the way that their faces are made up. The ear canal, the eustachian tube in a younger child is a little bit shorter, it's a little bit narrower, and it's a little bit more horizontal compared to a younger child or adult. And therefore, the pressures are different, and it's very easy for nasopharyngeal organisms to make their way into the middle ear. Also, infants and younger children get more cold, and that causes pressure changes, and that also allows these organisms to get into the middle ear. As they get older, the ear canal gets longer, the ear canal gets broader, and actually gets a little bit, it drops down and becomes more of a vertical orientation, and it just becomes physically harder for these organisms to make their way into the middle ear. Males are at higher risk. Also going to daycare puts you at higher risk because you're exposed to more organisms and germs there. Secondhand smoke is absolutely related, linked to increased incidence of otitis media. And as we mentioned in the nutrition chapter, children that are breastfed have a lower risk of otitis media in infancy. Certainly anyone who has craniofacial anomalies may put them at higher risk for otitis media. We've already kind of discussed cleft lip and cleft palate briefly. Certainly patients with cleft palate are at higher risk for otitis media. These are the common bacteria that cause otitis media, strep pneumo being the number one. When we talk about Haemophilus influenza, please remember it's the non-typable ones, not type B. It's the non-typable ones, and the third most common cause is Moraxella catarrhalis. Viruses can also cause otitis media, but when we're talking about otitis media, just think of these bacteria. Clinically, these patients will present with earache. It is not going to be exacerbated by manipulation of the ear like we see with otitis externa, but they will have ear pain, they will have fever, they can actually, the eardrum can rupture and then you can have a purulent drainage from the ear canal. They can be irritable. For some reason, infants can have diarrhea associated with this, or sometimes they just don't have a whole lot of symptoms. But look for fever, fussiness, irritability, and then you have to look in the ears. The diagnosis, there is no best test that you can order. The diagnosis is looking in the ears and seeing an inflamed, bulging, red, injected eardrum. There's loss of landmarks, and you should always do pneumatic otoscopy. That means that you have to basically blow in a little bit of air with your otoscope, and you will see limited or no movement of the eardrum itself. Sometimes the eardrum can be actually retracted. Usually it's bulging. It can sometimes be retracted, and you will have loss of the landmarks behind the ear. Sometimes you can actually see fluid levels and bubbles. So here we have a patient with otitis media. You can see that the normal landmarks are lost. You can make out a little bit of a landmark here, but you can't make out the bones behind the eardrum. You can also see that there is loss of the light reflex. Usually you should have a nice pearly looking eardrum and a nice shiny triangular light reflex. You're not seeing that. And also see how red this entire eardrum is, and you can actually see injected blood vessels. Otitis media with effusion occurs after repeated infections and there's not enough time for the fluid to resolve. Typically, otitis media is like a little abscess in the middle ear, and the fluid eventually resolves, but if you don't have time for that to go away, you will see it behind the eardrum when you examine the patient. So you can see a full eardrum or a tympanic membrane that's a little bit retracted, and there's not a whole lot of erythema of the eardrum with otitis media with effusion. Here you see a patient, again, there is a redness. This is some redness, and you can make out a little bit of fluid down here, and it really does, it will layer out because it's just by gravity. Treatment of otitis media is going to be antibiotics. The treatment is changing. I don't think that you're going to get asked too much about it. Recommendations now are age-based. Certainly in Europe, a lot of otitis media is left alone because we know that it resolves on its own. But certainly in this country, under 2 years of age, you do treat otitis media with antibiotics. If the child has severe pain or systemic illness, it's also recommended that you treat with antibiotics regardless of the age. And the first-line drug is still amoxicillin. It has been for years. It's just used at a higher dose now. The other thing to remember for the exam and for your patients is if the patient is not any better after 2 to 3 days of antibiotic treatment, then you should think of the baby has a beta-lactamase producing organism. Moraxella catarrhalis all of them are 100% beta-lactamase producers, and so will be resistant to amoxicillin. So if your patient is not any better after a couple of days, consider changing to an antibiotic that will cover beta-lactamase producers. Myringotomy or tympanocentesis. Myringotomy is basically, and tympanocentesis is basically making a little hole in the eardrum itself. It's sometimes used when there is no good response to antibiotics. It just lets the eardrum drain. Also, if there's other complications, it just lets the middle ear drain out. These are myringotomy tubes. These are placed for various reasons. If you have too many of these infections, if you're having hearing loss problems, then it's recommended that you place myringotomy tubes. They're also known as PE tubes or pressure equalizing tubes. They are placed surgically by the ENT in the eardrum itself, and they then allow for equalization of pressures between the middle ear and the outer ear. And they also, if you do get an infection, they let the drainage come out. These basically extrude on their own after 1 or 2 years. Otitis media with effusion should be followed closely to make sure there aren't any complications. Typically, you don't need to treat effusion. That fluid will resorb on its own. A lot of studies have shown that, so you don't need to retreat with antibiotics. You don't need to give decongestants or anything like that. If you leave them alone, they tend to go away on their own. You do need to follow their hearing, because if you're starting to have hearing problems, that means that you're going to have language problems. And this is kind of an aside, but please remember, especially for the test too, any child with a hearing problem with delayed speech. Any child with delayed speech should be tested for hearing problems because they are very related. If you're not hearing well, then your speech may not be normal because you're only repeating what you hear. But again, these patients don't need a whole lot except for observation. The tympanostomy tubes are recommended then if you are having hearing problems. Complications of acute otitis media is hearing loss. That's the most common complication. Sometimes actually patients will have some hearing problems while they have the infection themselves. Imagine you have a little bit of fluid behind your ear. These patients feel like things are kind of fuzzy, they don't sound right. And when it goes away, when the infection is treated and resolves, the hearing comes back normally. But repeated infections with otitis media can cause hearing problems. Also, it can cause mastoiditis. Remember your anatomy? It can go from the middle ear back to the mastoid bone. In that case, you will see the ear is pushed forward and there will be some redness and tenderness over the mastoid area. The eardrum can perforate and sometimes that actually relieves the pain. It can then heal and scar up. However, sometimes you can have the next complication, which is a cholesteatoma. And a cholesteatoma is a little bit of squamous epithelium that gets into that area and then it starts to grow and forms a tumor and can cause very destructive lesions to the bony area there, really affect the hearing. Meningitis is the most common intracranial complication of otitis media, so that sometimes you can have a breakthrough meningitis. And labyrinthitis is another complication of otitis. These patients will have ataxia secondary to that and kind of get dizzy and sometimes vomit and stuff.